what you're about to see is a number of vignettes that are going to help you with your pre-op experience and when you come in for your check-off for your IV skills. So you're going to come in, you're going to prime an IV, you're going to start an IV, you're going to hang a simple medication by secondary, and then you're going to administer a pre-prepared IV push medication. The expectation will be that you will look up that medication prior to giving it, and you'll have the knowledge to give it safely. You'll have 30 minutes to do these skills. So it's really important that you come in and you practice prior to the actual check-off experience. In addition to this, we've done a pump vignette so that you can actually see how a pump is used, because we'll see those on the units, and how to change an IV from one that's existing to another one and to give another medication. So it will help to reinforce some different skills. But this is not what you will be checked off on. This is an additional vignette. Ready to go? Mm-hmm. Okay, I'm going to demonstrate priming a tubing. So I've already looked at my MAR and compared it with my doctor's order to make sure it's the right solution. The bag is not wet. The expiry date is good. I've got the correct tubing, so I've looked at the doctor's order. I've looked at in most instances we'll be using a pump, but in this case I'm just going to run an ordinary with an ordinary IV tubing. So the first thing I do is when I get this out of the package, I make sure I close the clamp. If you don't, you're going to have solution everywhere. A lot of the hospitals will use an extension tubing. This is a good time then to open the extension set. And remember that you can look at the tubing if you're running this by gravity flow and not with a pump to see what the drop factor is. So I'm going to just attach this to the end of my tubing. Keeping it sterile. If I have touched it, I will cleanse with my alcohol swab. This one, the slider is open. My tubing is fine. I'm now going to attach sterile to sterile. What they call spiking the bag, so keeping my fingers away from the port here. Twisting, turning motion. And it is easier in clinical practice to do that than with the bags we have in the lab, which are a little stiff. Now I'm going to hang this up. For my patient, I want to make sure that the solution is facing outward so that when I come in the room I can see what that is. And I'm going to squeeze the drip chamber so it's half full. Now, there's a number of ways that you can do this, and a lot of the nurses will just open the flow clamp and they will just run the solution. When you work with the Alaris pump, which I'll show you in the next vignette, if you get air in the tubing in any way, then the machine will beep. So I'll show you at least in one port how you can remove air from a vent. So air rises, so a vent normally would be hanging like this. Invert it or turn it upside down because air will rise. Slowly run the IV solution, which is going to start here, until it gets close to the port here. And the one thing, the lower that you hang it, the faster it will run. If you get bubbles, you can flick them. There's always extra in these bags, anywhere from 5 to 10%, so you don't have to worry about that. I'm going to come now slowly to the port, and then I'm going to flick it to get rid of the bubbles. And I can tell already that this one has a fair number of bubbles. So you can see the solution now is slowly moving as it gets to the port. I'm going to start flicking with my finger here. I always keep my control clamp in the upright position. once I clear the flow clamp, and you can see the bubbles now coming out as I flick. You can see that by having it running slightly, that helps to move the bubbles. I can turn it off now and go to my next one. So everything looks pretty good. Up here I have a few that are above. Before I move further, I can just kind of look. There seems to be a particularly bubbly solution to it. I can now move to the next one. Now, I'll do one more, and then I'm going to run them through like you will see mostly in the hospital setting. All right, so again, slowly turn it on. You can see where the solution is by the first hub there. I'm going to turn it on slowly. You're in charge, so the faster you turn it on, the faster it's going to run like crazy. So you can see, there you go. I'm not going to worry until it moves up past my clamp. The lower I put it, the faster it will run. Here it comes up to the vent. And again, the same thing. I can slow it down a little bit, keep it running, and start flicking. So hold it between your fingers. Start flicking. And this one, you can see the bubble there that came out of it. Turn it off, and away you go. Now the rest of them you can continue like I've shown you, or you can now run them through. What is important though, and we see this in the hospital all the time, is the nurses put this in the sink, they turn it on, they let the solution run out, and we know that if solution can come out of here, that this is not considered sterile because microorganisms can get in. So what we're going to do instead is pop this off, hold it in our fingers, turn this on, and you'll notice that this clamp has a fat end and a thin end. The fat end is open and the thin end is closed. So if you always hold it like that, you'll know what your IV is doing. So I'm just going to now go down here to the garbage or whatever, but notice I haven't put this in the sink, and I'm going to now let the fluid flow out. And when it gets to the garbage and empties out, I can now recap it, and I'm ready to go. So we're going to stop there for a moment. Okay, the last thing I'm going to do is I'm going to put a sticker, which you'll either find in your med room or in your utility room, and I'm going to label this tubing so that the nurses know when it needs to be changed. So a lot of the hospitals, in your textbook it says 72 hours. A lot of the hospitals have gone to 96 hours to change their tubings. So just a quick review then. You need to remember your sterile principles. Sterile to sterile is sterile, so touching this to here, you need to maintain the sterility. We need to remove the air bubbles, and a lot of patients are afraid that even a little bit of air bubble will give them an air emboli just because of what they see on television. But my philosophy is if you can see it, get rid of it. So I've shown you two methods, one of which to flick the ports, and two to run it through. The less flicking that you do, the less bubbles you generate. And then lastly, remember that if an end is wet, it's considered contaminated. So if you just put this in the sink and allow it to get wet and drip fluid all over, you cannot guarantee the sterility of this of the end of this. So we need to be very aware of asepsis. All right, we'll move then to the next.
Okay, now we've established priming our IV. So we're going to go into the patient's room in the preoperative area, and we're going to go ahead and start the IV. And we introduce ourselves, we wash our hands, we check our identification, and make sure we have the right fluids. And before once we get in the room and we hang up our bag, I like to put my tubing, I like to hang it up, but right after I get my supplies ready, then I will bring it down closer to the patient. That way this doesn't fall on the floor and get contaminated. Now when I open up my IV start kit, this is what it's going to look like. It's an IV start kit. And inside of it, it has a Tegaderm, some 2x2s, and a prep. And sometimes in the hospitals you'll have the ones that clip at the end, and they have a big sponge on the end. This one is just a small one that you just crack it to load the fluid in. So I've pulled that stuff out. I have my prep open. This is before I put my gloves on. If you want to put your gloves on before that, you can. And then I open up my 20 gauge IV catheter. And you want to have a patient with a 20 gauge to start your IV preferably, or you can use an 18, but they typically go with the 20, just in case the patient is to receive blood in the OR for some reason. And I go ahead and clean my surface, and then I put my strips of tape there just to make sure that it's on a clean surface. And by this point, I usually grab the patient's hands, I ask them if I can see their hands, and I look for a vein that I may want to pick. Also, you can apply the tourniquet. Make sure it's tight enough so that the veins can fill up in the hand. And I'm going to go distal to proximal, which is farthest from the body to closest to the body. And I'm going to look at the hand and decide where I want to go. Sometimes patients have really good veins, so you've already made your decision where you're going to go. So you can check before, or you can make your decision then. So now I'm going to make a second look, make sure that I have everything ready to go. I'm going to go ahead and put my tourniquet on. And as the hand is filling up, and this goes a little quicker at the time of the actual IV start. I'm going to put my gloves on, and I'm going to take out my prep, and you just press on this till you hear a crack. And I've chosen this vein here, and I'm going to go ahead and prep it. In most hospitals it's for 30 seconds, and so you scrub it for that long period of time. Okay, so it's been 30 seconds. And now it takes it's a lot quicker on a regular person for the site to dry. On the mannequin it takes a little longer. So for the sake of the video, we're going to proceed here. I'm going to uncap my catheter. As you see, the catheter has a sheath over it. That's the part, the catheter itself is over the needle because we need the needle to pierce the vein in order to thread it inside of the vein. The needle is just there for the introduction of the catheter. There's grips here on the side of the catheter, and that's where we're going to hold on to. That keeps our fingers from sliding, the grooves here. And we're going to go inside with bevel up. And whenever you're going to start your IV, you can use your thumb on your non-dominant side to stretch the skin back. Be careful whenever you go to start your IV that you do not touch it, that you're far enough back, and that you do not touch it with your catheter and contaminate the catheter. And make sure you have your stuff right next to you. And then also at this point, you want to have your tubing close by so that you have something to connect to your IV catheter. So now I'm going to go ahead and start. I usually ask the patient, I'm going to go ahead and stick you now. Don't hold your breath. That's when patients will pass out sometimes. And then I go ahead and make my decision. I'm going to start the IV. And I have blood return in my chamber. At this point, you can advance just a little more if you're pretty far out with your catheter, or if you're further in, about halfway, you don't want to advance too much because you don't want to blow the vein, which means you would go through the other side. So now I'm going to go ahead and advance with one finger forward, holding this part still. Once I've advanced with this piece here, then I'm going to snap it back and hold here so that it doesn't come apart. Once I've done that, I can take a deep breath, release the tourniquet, and as you can see, this looks easier because I switch hands a little bit in order to get my dominant hand free. So now I'm going to take my 2x2s, and I can go ahead and lift this so I can place them flat under here. Don't bunch them up. The needle is no longer in the vein. And I'm going to put some pressure further past the site and grab the hub, pick up my tubing, and I'm simply going to flip the cap off, and I'm going to take the needle apart right here, and I'm just going to drop it and attach it, holding onto the hub carefully over here, not to twist that side because the catheter will turn inside the arm. Once I've done that, this is what the 2x2s are for. Most patients don't bleed this much, but if you have the tourniquet, if you leave the tourniquet on, they will. So I'm going to clean up my site, and you see how I've switched hands because I'm better with my dominant hand. Now, I'm going to check the patency of my IV because I've just done a lot of manipulation with the catheter and I want to make sure that it's flowing well. So now I need to go ahead and turn on my IV. I like to see that it's dripping, and I look down to make sure that it's patent. There's no infiltrations, redness, edema, or pain on the patient's side. And then I like to make sure it's flowing really well, and it is, because that means they'll be able to access that very well in the OR. And then I'm going to turn it down to the order on the chart, which is in pre-op, it's typically keep vein open. It's called KVO, and that's just enough to keep the vein open. So I'm satisfied with that right there. And then I'm going to go ahead and tape my IV. I place my tape over the hub. You'll see different ways of taping. Whichever the nurse in pre-op chooses to do, just go with what she chooses to do. This is just the way that I tape. I place a piece of tape over the hub, and I support my IV till I have a second piece of fastener on the IV site, because I've almost pulled them out before by accident. It's a little bit heavier once you put your line on. Now I have my tegaderm, and this is the last piece that's sterile in your pack. I put it right at the hub, right here. And then I press it down. It lays very nicely on the IV here. And I go ahead and make sure that it's pressed down. I follow it as I'm pulling off my tegaderm. Once I've done that, I need to save this piece for the end to label my IV. Then what I tell the students is to look at which side has the most skin showing from the top. That would be ideal for putting your IV tubing, which side to curl it over to. So now I have this side, and I take another piece of tape. And of course this one would be longer, and I can tape over the same site so that this doesn't pinch off. And then with the extension tubing, it makes this line a little bit longer. Some hospitals don't use them, but look at this here. Your tapes have to be a little bit longer. And then this piece up here, I simply go underneath it and make it a straight piece like that, and so that if anybody comes in to do an IV push, such as anesthesia, this is nice and fastened for them. And you can also put one more over here, but less tape is better. And then I would label my IV with my initials, date, and gauge, and I would go ahead and put it on the tegaderm. Whereas not to cover the site, so that anybody that's pushing medication can assess the site at any time. And then I would clean up my mess so that none of this ends up underneath the patient when they go to surgery. Okay, a few points that I'd like to make on starting your IV is if you get blood on your gloves during the process of starting your IV, go ahead and put a piece of tape over the hub, and then you can remove your gloves and finish taping. That way you don't get blood on the tubing for the other health professionals that are coming after you. The other important point that I'd like to make is to make sure and clean your table for at least one piece of tape. A lot of facilities don't want you to put tape on the table. They want you to tear it as you go. So if you need to do that, then keep the tape next to you and at least take the piece off so that you can grab it very easily. Also, for this IV checkoff is for pre-op, and they don't typically put a label on their tubing in the pre-op area because most patients are there for one day. If they plan to stay longer, they'll usually convert this over to the Alaris pump tubing, and then they will add a label onto it. Also, when you go to your chart, once you've finished your IV, you're going to make sure and document. Documentation is very important. So if you were to try twice, 2 attempts for an IV, then you would say, IV 20 gel coast started in left hand, whether it is the hand, whether it is the forearm, and then you would document the gauge and the date and time and whether there were any issues. Sometimes you'll have an infiltration, so you'll need to say infiltrated, DC'd. And then you would go over and you would write down the successful IV on the second line. You need to document each time you stick the patient.
So the next thing we're going to do in your checkoff is you're going to hang a secondary medication. So again, we've checked the order, we have the MAR, we've checked our patient, we've asked the 2 patient identifiers and certainly checked for allergies, and we're going to hang Rocephin. So maybe this is in the preoperative center and 30 minutes before the patient runs to the OR, we need to make sure that they get their first antibiotic. So we need a secondary, the very first time that we're hanging a secondary set, we need a secondary IV tubing, and it also will have the hanger. Again, just like when you were doing the primary tubing, you need to take it out of the package and you need to clamp it off because it's open, and if you do not do this, when you spike the bag, the medication will all run out on the floor. This also comes with a hanger, and the principle of hanging the mini bag, which is a small bag like this with the medication in it, is that the bag that hangs the highest is going to go first. So we're going to put this up higher, and we need something to lower the primary bag down. So we use this hook to do that. Our primary bag, we have our hanger for our primary bag. Again, we want to hang it lower. It will come like this in the package. Hold the button towards you. There's a little knob on it here. Pull that down and sort of snap it in place. Put the hook through the bag. Hang it up, and again hang it up so that this is towards you. So when you go in the patient's room, that you can actually quickly see in one glance what's hanging. Now I have the Rocephin. We've got our secondary tubing. We've clamped it off so we make sure that the medication isn't going to go anywhere. And again, the same principles as what we did earlier. Sterile to sterile is sterile. So we're going to take off the end, and for some it will be like a plastic cap that you really need to pull. Pull this off, and again with a twist turning motion, get your medication bag onto the spike. Hang this high, again the principle being that the smaller bag, the one that's hanging high, will go first. Now you'll notice that there is air in the tubing, and that's fine as long as you don't open anything up. But if you open it up without getting the air out, then the patient is going to get air in the line, which you've so carefully primed earlier. We're going to take an alcohol swab, and what I often see students do is they go, so please don't do that. Make sure that as much as possible that you keep the area that's going to scrub the hub clean without your fingers on it, or sterile without your fingers on it, and you're going to clean the port. And it's the port, the highest port that you want to clean. And you're going to end up putting the end of the secondary tubing onto the primary line. So again, scrub it well, about 30 seconds. Good indicator. If you're working with the pump, what I recommend is that all this garbage goes on top of the pump, and we'll show you a pump in a minute. But the pump will not be part of your checkoff. Again, with the twisting motion, attach your secondary line and make sure it's secure, but not so secure that nobody can get it off. Now we're going to do back flushing. So in order to get fluid in this line, we know that with the solution in this bag is compatible with your IV secondary med, or we couldn't hang it. We made that check. So we're going to now lower our medication bag down below the secondary bag, and we don't want to open it until we've got it below, because we don't want this medication going into there. We're going to get it lower. Again, we're going to hold the clamp so that when it is open, the fat part of the clamp is up. And we're going to just open the clamp, and you're going to see this run very quickly, and the solution come back into the secondary tubing. There it comes. It's coming up now past the clamp, and you'll see the bubbles going into the medication. That's pushing the air that's in the line out. The faster you do it, the lower you put it, the faster it's going to go. When it gets half full, you can turn it off. There's no air in the line now. It's totally turned off. You hang it up. What I tell my students is that the only time this is open is when you're running it to the patient. All the rest of the time it's closed. So now we would know, we would have figured out our rate, and we would regulate this, and this is what we would call a gravity flow IV. There is no pump, so we're in the land of hurricanes. When the power goes out, we need to know how to do a drip factor and calculate the correct drip factor in order to run this medication at the desired rate. So again, same principles as the priming of the bag. Sterile to sterile is sterile. Make sure you keep the spike sterile, the end of the bag sterile. Keep it closed when you first go to, before you spike it, because otherwise the medication will run all over. When I do this and I regulate this, I'm going to open this fully up, and I'm going to regulate the drip rate from here. So you can see that if I turn that down from here, I can slow it, and if I open the clamp, I can speed it up. So it is this one that regulates the flow to the patient. Now the other really important part is that you just hang a medication. We've checked that it's the right patient. We've checked their allergies. We're giving this maybe for the very first time. We want to make sure that we're going back and reassessing that patient. So if you're hanging this and it's to run over 30 minutes, in 15 minutes half it will be gone. 5 minutes you want to come back and check your patient. 15 minutes you should check it, and you should be able to see that half of it's gone. And in 30 minutes it should be through. So don't forget the assessment piece. Obviously the documentation of the medication will be on the EMR, and so you'll want to make sure that you have recorded it there. Okay, so now we're going to begin to show you how to do an IV push. So this will be the last skill that you will demonstrate when you come in for your skills checklist. We're not going to draw up the medication here, but we have Lasix here. And the order's for 40 milligrams of Lasix, and it comes in 4 mils. I've diluted it because a lot of times the medication is hard on the vein. But you'll again look at your agency policy, and you'll also look at your patient's veins and their experience to determine whether you're going to dilute it or not. And a lot of times if you're getting a very small amount of medication, you need to dilute it because you can't give it over 2 or 3 minutes. If it's just a half a mil in your syringe, it's very difficult to give a half a mil over a 4-minute period. So for the purpose of this exercise, we've drawn up our IV push medication, and I'm just going to get my flush. And remember that the flush is normal saline. It always has air in it. So pull back, hold it straight up in the air, push up, and again, don't shoot it across the room, because when you make this all wet, you can't guarantee sterility. So you can, I always say to students, try to pretend this is the last medication in the world and practice getting it just correct. Then put your cap back on. So I'm going to come to the bedside, and you'll notice that I have labeled my Lasix. So because I could end up, when I do protonics, having 10 mils of flush and 10 mils of med and not having a clue which one is which. So when I come to the bedside, I want to make sure that I've got, I know exactly what it is and the rate at which I'm going to flush it. And it's not uncommon for students to be giving 2 or 3 IV push medications, one after another after another. For the purpose of this exercise, we're giving 1. So I've got my flush, I have my IV medication, I'm taking my alcohol swabs with me, I've come and seen the patient, I've identified them, again I've looked at their allergies, and I've told them that now I'm going to be giving them their Lasix this morning. So this is a running IV. So in most cases when you've got a running IV, you know that the site is fine, everything looks good, so you do not have to flush before. So, but you will flush afterwards, because when you put the medication in this port, you're going to have medication from here to here, and if you just hook it back to the pump, it could, if it was digoxin or a very serious medication, go faster or slower than what is desired. So this way, when we flush afterwards, we make sure that that medication gets in at the appropriate rate. So I've made all my checks. I'm going to get my IV push medication, clean the port, and because this is a running IV, I don't want the medication, when I give it, to run up here and to run up here. I want to go all in the same direction. So if I was on a pump, I would put the pump on pause. But I'm on a gravity flow IV, so I could turn it off here. Or what you'll see the nurses do is they'll just pinch it here. So when I'm away from the site like this, I don't wear gloves. If I was doing this through a PICC line or a central line where I'm pulling back to get blood first, I would be wearing my gloves. So I've got it pinched, I've got it cleansed, and again I've cleansed it for the 30 seconds. I always tell my students to keep their cap sterile in case they get pulled away or carried away and need to come back and cap it for some reason. They can't continue for the moment. They still have their cap. So again, I'm going to make sure that I have solution right to the end, which I do. I'm going to attach my syringe. And while I'm doing that, I'm both looking at the patient and I'm looking at their site. The last thing I want to do is give a lot of concentrated medication into an IV that for whatever reason has just decided to blow. So I'm really watching that. I also know that when I give this, within 5 minutes, the patient is going to get the full effect of this medication in terms of feeling it. And I want to make sure that I'm watching them for breathing, etc. So now I've got my watch on. And in lots of rooms there is a clock. I try to start at 1:45 or 12 o'clock, sometime that I will know, and I want to push this over a period of 2 minutes. So I'm going to now start, and I'm going to slowly begin my push. It should go in easily, and it's not a start-stop. It's a slow pushing, making sure that it goes in over the appropriate length of time. So I'm not going to stay here and do this fully. So I'm going to now say the medication is in, and now I'm going to flush. So remember, I'm going to keep it pinched. I have medication in this line. I'm going to undo this. If I don't touch the port, I don't have to clean it again. I'm going to take this off. Keep my cap sterile. How you doing there, patient? Make sure I got solution right to the end. Attach my flush, and at the same rate, I'm going to put my 4 mL of solution in here over 1 minute. So again, watching my clock, get to the 15-second mark here, and I'm going to gradually start my push. Now I'm ensuring that that medication is going in at the same rate and the patient's going to get it all. Once that's finished, I'm going to undo this, unpinch my line, check that it's running at the appropriate rate, get rid of my supplies, and then again I want to make sure that I'm going back to check on my patient, that they have their call bell, but I'm also just not going to leave them, and there's going to be some reaction, some adverse reaction that's not expected to that medication. So I'm going to be back in here to check on them, to make sure everything is fine. I'm going to document this medication in the MAR. And if it is Lasix, one of the things you want to do if they have a Foley catheter is empty their catheter before, and make sure that that you're checking what the outcome is of the Lasix. You should see increased urine output following. Okay, just a couple of things that you need to know is when you get to your checkoff, you'll be giving a medication, and they give you the name of it, and you'll have about 10 minutes to look it up. You want to look up the signs and symptoms, how fast you need to give it over, how you're going to reconstitute it, whether you need to dilute it or not, whether it's compatible with the IV solution that's hanging. Remember that this bag is just normal saline, but it is quite feasible in the clinical setting that you could have potassium added to that bag or some other medication, and if it was hanging, you'd have to make sure that it was compatible. And if it wasn't compatible, you would have to flush before and after this medication in order to deliver the IV push medication. So the expectation is in 10 minutes that you're able to look up that medication and safely be able to reconstitute it and give it. So